Hello and welcome to Syncope and Near-Syncope, Cardiac and 12-Lead Concerns. This is part one of a 2-video series. This is Sean Halsman, education guy and paramedic, and this is a CME that we're doing to kind of improve everybody's understanding of some 12-lead concerns that we have in the face of people who have passed out or are nearly passed out. This is a 2-part series, like I said, and there is a quiz on the ePro system following the completion of these videos, which you can take to get your CME credit for this. So please buckle in. Thank you for joining, and we'll get right to the heart of our matter here. The objectives for this presentation: explain the mechanisms of syncope. Syncope is something we get called to pretty frequently, and we're going to go over why people pass out and what the general understanding is of syncope. Identify some features of a normal 12-lead ECG. I do believe that 12-lead ECG is really underused in our field in a lot of cases, and we're going to talk about normal 12 leads, what we should be seeing on those, and how we can identify if there's problems. We're going to identify anomalies on the ECG that may be of concern. Specifically, we're going to deal with 5 presentations on the ECG that might be things that could tip us on to more serious problems. And then we're going to explain the importance of obtaining a 12 lead on patients with dizziness and syncope. Hopefully we'll walk away with a little better understanding of when and why to get the 12 leads here. So let's talk about syncope. What is syncope? This is generally defined as a temporary loss of consciousness caused by a fall in blood pressure. So when we get into discussions of syncope, we're also going to count near syncope, which would be your transient dizziness or nearly passing out. Those are important as well, because a lot of times you'll get a call for a syncope and you get there and it hasn't really been a syncope. The person didn't really pass out, they were just dizzy, and people sometimes discount that as not as big of a problem, and it shouldn't be blown off like that. So there's many causes for syncope. There's a lot of reasons why people can lose consciousness, but whatever the case, we shouldn't be considering syncope as no big deal. And unfortunately, sometimes we get a little bit full of ourselves, and or maybe we're having a bad day and we just don't take the time to think about what could be happening. So it's not no big deal. Syncope does happen to people. In many cases, we'll get to a syncope call and find that there's really nothing for us to see or to handle, and there are no abnormalities. But syncope is not something that should normally happen to you. We don't get up in the morning and go get a cup of coffee, head to the store, pass out. That's not usually within the realm of our daily goings on. So it's not a big deal, and if we can keep this in mind, especially when you get there and the person is not complaining of anything, we can't blow this off and just assume that everything is fine, and there's reasons for us to do some greater assessment. Here's a historical fun fact. Young ladies, like this young lady right here, back in Victorian times, women were said to have the vapors, and occasionally you'll still hear an older person say that someone got the vapors. This was actually a bucket term for a lot of things that females of the day experienced, but passing out was one of them. And if you consider the clothing that women were wearing back at this point in these tight corsets, they actually believe that women used to pass out because of the fact that their corsets were so darn tight that they were constricting blood flow and decreasing the respiratory ability of the chest cavity from expansion. So these really tight corsets, squeezing in are the main issue for most of these women. But little historical fun fact, it used to be called the vapors. So before we get into this discussion of passing out, we'll talk a little bit about blood pressure. And we found in the definition of passing out, or definition of syncope, that it's a sudden loss of consciousness due to a drop in blood pressure. So we'll talk about blood pressure and mean arterial pressure. So this MAP, or mean arterial pressure, is something we're going to see in the collaborative protocols as they come out for New York State very soon, and it will be in reference to a specific drug that we're going to carry. What pressure is in your arteries at any given time is considered your mean arterial pressure. We can measure this with an indwelling blood pressure device, which you'll see if you go into ICUs or CCUs or trauma ICUs. They'll have these in, and they can get a second-by-second mean arterial pressure. For us in the field, we can do a simple math equation and actually figure out what the mean arterial pressure is. But before we get to that, 60, this is a number we should have in mind, 60 millimeters of mercury is going to be considered the mean arterial pressure that is needed to sustain adequate blood flow to body organs. So this is what we need to perfuse various organs. So we should have a MAP of at least 60 to get that done. This is the really simple math equation, and it's systolic pressure plus 2 times your diastolic pressure divided by 3. So if trying to figure out what the mean arterial pressure is, that's how you do it. So let's take a look at the classic example of 120 over 80. All right, if we're using this equation here, you're going to say 120 plus 2 times the diastolic, so 2 times 80 is 160. And that's going to give you 280, and then you divide that by 3, and this equals 93.3. So 93.3 would be the mean arterial pressure for a person who is having a blood pressure of 120 over 80, which is good. So we have happy times here. So we have a mean arterial pressure that's going to perfuse all the organs, and everybody is happy and swell, and that's awesome. Now, let's look at the converse here. Here's a pressure of 60 over 40. Regardless of what you find in the mean arterial pressure, I hope that the first thing you want to do with this pressure is give it fluid and possibly vasopressors, because I hope we all recognize that this is a pretty crummy pressure. But if we do the math here, you have 60 systolic plus 2 times the diastolic, so 2 times 40 is 80. This is going to give you 140, and then you divide that by 3, and that is going to yield 46.6. So 46.6 here, if we take a look at that, is going to be a bad mean arterial pressure. So we're not going to be perfusing organs as well as we'd like to, and that's going to cause a whole host of problems, and I'll do the accompanying sad face here. So this is a bad pressure. So again, hopefully we're throwing fluid at this and doing other things to try to fix the problem, but this is a bad pressure, and it's a bad pressure not just because it's low, but because it's dropping the mean arterial pressure as well. And what does that do? Well, which organs are affected by low mean arterial pressure? All of them, and your whole body is obviously affected by your pressure dropping, including your skin and other organs. However, your brain is one of the specific organs that's really affected by drops in blood pressure. So brain, heart, lungs, basically any of your really high metabolizing organs are going to be affected by this. And what do we see in people who have low blood pressure whose brain is not perfusing? Well, in shock situations, we're going to see syncope, people passing out. We're going to see anxiety, right? Because that's one of the first things your brain does when it can't get oxygen, is it gets you a little anxious there. We may see altered mental status. So all these things are going to pop in when the brain starts getting blood flow. And just consider your heart is here, and if you're not pumping enough fluid up there to your brain, then we're going to have some issues, including passing out or getting dizzy. Why do we have sudden drops in blood pressure? Well, it could be a couple things, but I like to think of the entire circulatory system as a very simple water pump type system. So you have a pump, which is your heart. You have the fluid, which is your blood. And you have your container, which is the arteries and blood vessels. All right. So those are the three things there. And if you think about firefighting or anything else, if you're pumping water from a pumper through a hose onto a fire, your pump is the pumper, the fluid is the water, and your container is the hoses. So a problem with any one of these three parts of the system is going to cause issues. So pump. All right, you have a heart attack and you have your cardiac tissue, your cardiac muscle that is no longer pumping properly, or it can't squeeze properly. That's going to drop your blood pressure. You're not going to be able to get enough fluid out there. The other thing we need to think about are dysrhythmias. So bradycardia is going to be too slow. So you have a heart rate of, let's say, 30. So you got bradycardia. This heart is not going to be able to provide adequate pressure with a heart rate that low. At the other side of the spectrum, we have tachycardias. So let's say you go into a VT. Well, the ventricles here are beating too fast to actually refill and get proper preload. So these two dysrhythmias can actually cause you to drop your blood pressure. That's a problem with the pump. Here's one you should recognize. All right. VF. If the heart goes into sudden VF, it doesn't pump anymore. It quivers. We know that. So that's going to cause a drop in blood pressure as well, and cardiac arrest, obviously. But these are, things that happen to your pump that are going to screw that up. How about the fluid? Well, you have blood. The blood flows through your body. So, here's your head. Here's your feet. I just like drawing with this pen, so this is cool. So the blood is circulating all through your body here. Let's say somebody decides they don't like you and they poke you in the abdomen with something sharp, or you are shot with a gun. All right, where's the fluid going? Out and onto the ground. So if you don't have fluid in your system, obviously we're going to drop blood pressure, so this would be bad as well. That is why trauma patients have to get to the ER or the OR as soon as possible so they can stop that bleeding. If you have bleeding internally, all those things. So losing fluid is going to cause a problem, obviously. And then last but not least is your container. So there's a few things that can happen that will actually expand your blood vessels, dilate your blood vessels, and some people take medications for these, nitroglycerin. People who use ED drugs after using nitro can have this massive vasodilation. Spinal cord injuries can cause massive vasodilation. So if your container is dilating and getting bigger, then your pressure drops as well. But in general, dropping of blood pressure is due to one of these three things: pump, fluid, or container, and that's going to cause you to pass out. What does it look like? You have probably seen people pass out. We've all certainly seen people unconscious. And what people who are not trained in EMS or in medicine are going to tell you are some of these things. So your bystanders are going to say there was a total collapse. So there's loss of consciousness. The person was standing there and then all of a sudden they dropped over. Guys do this on the altar when they're getting married because, we can't commit. Seizure type activity. I had actually 2 calls right in a row the one week many years ago when I was on the road a lot more, and they both came out as seizures. And when we got there, they were both ventricular fibrillation cardiac arrests. And so the sudden drop in blood pressure caused a little bit of a shaking and seizure type activity, and then that rolled right into the cardiac arrest. Eyes rolling back. Sometimes it's a near syncope, so you'll get these weird presentations like a patient is staring off into space, or they're just not responding. Their eyes are open, but they're not really talking. You can get moaning, agonal respirations. Urinary incontinence comes up a lot of times with seizures, but that can happen as well. And then bizarre behavior. So if you're not perfusing your brain because your pressure's dropped, then sometimes you just act silly or you say things that don't make any sense. And again, these are all things that could be described. So there are other presentations as well, but if you're getting this type of thing where a person has had some kind of fleeting loss of consciousness or fleeting goofiness, we want to start thinking about syncope and perhaps what is happening with that patient. As I said before, there are many reasons why people can pass out. We're going to be most focused in this presentation on some of the cardiac concerns because these can be a little bit sketchy and sometimes sneak up on you. And the main point to remember is this: just because the patient is alert when you get there doesn't mean things are okay now. So here's some things that are going to fool you, and I know because they've fooled me in the past. Youth, athleticism, and general good health. So people who have these things going for them, when they have a dizzy spell or a syncopal episode, and then you get there and then they're awake and conscious and they don't seem to have any problems, these are going to be masks that that situation is putting on that patient for you, and they can be blinders. Combined with that are excuses you're going to hear. So a lot of people will say, oh, I'm just dehydrated, or I've been working out a lot, or it's, a lot of stress. I just got over being sick. I probably because I was throwing up. And this is all stuff that we should be, especially as medical providers, we should be really concerned about, because these are things that people say when they're denying. And remember, one of the first things that guys especially do for heart attacks is deny. Well, this is denial. This is, I'm fine. I don't have a problem. And what they're really saying with this is, I don't want to go to the hospital because I have stuff to do. And that's not a good reason to not get checked out at the hospital, as much as I would probably say the same thing. Our job as a medical practitioner is to, do a really good assessment on people and to give them the best advice that we can. Sure, some people may not need to go to the hospital, and some people may be just fine, but we don't want to assume this or be lulled into the sense of security simply because the patient says they're okay or because they now look okay. there's a couple of cases that I was going to blow past you really quick here. Hank Gathers, back in 1990, he was playing basketball for Loyola Marymount, and on March 4th, he was playing a game, and he collapsed on the court, ended up having a sudden cardiac arrest at that event, and he died, shortly thereafter. Autopsy revealed that Hank had undiagnosed hypertrophic cardiomyopathy. So that's a big word, but really we'll talk about this in detail later on. This is a structural abnormality of the heart that's commonly causing people to go into sudden cardiac arrest. Hank had some previous dysrhythmias and actually was on medications at one point, but he wasn't taking the medications properly. So place your blame where you will, but the fact was that the dysrhythmias were caused by this undiagnosed heart issue that he had. Another young man, this guy was Chase Morris. He was 16. He was a Texas high school tennis player, and in 2013 he was at school. He played tennis, and he went to lunch afterwards and did some other stuff, and then he had a sudden cardiac arrest and died at school. And an autopsy for young Mr. Morris also revealed that he had undiagnosed hypertrophic cardiomyopathy. So again, I'm not sure if this is the first time he passed out, but it was the last time he passed out, and this was an undiagnosed problem. Dylan Rose is a 13-year-old young man from Monroe, Michigan. He was a three-sport athlete, including football. He was having syncopal episodes, so he was passing out a lot, and they were episodes that were associated with him being startled. So at one point, the story goes that his mom turned a blender on at the house, and it was loud, and he passed out. And after this happens a couple times, he goes to the doctor. They get him in for some cardiology consult, and they find out that he has a dangerous type of long QT syndrome, which we'll talk about in a little while. And he is currently out of sports, and he's actually going to get an implanted cardiac defibrillator. That's how bad his condition is. So multiple syncopal episodes leads to this diagnosis, and there he goes. This is Sarah Turner. She's from Birmingham, Alabama. She suffered a syncopal episode while she was home in bed. Somebody noticed. They took her over to the hospital, and she was diagnosed with Brugada syndrome. She's currently under cardiologist care, and she lives with lifestyle restrictions as well. So we're going to talk about these four syndromes, or these different situations. But here are four people who, if you walked up to them on the street, you'd look at them and say, hey, young, athletic, in relatively good health, no diagnosed medical issues, might let your guard down a little bit, but they are all people who have pretty serious or had pretty serious heart problems. So that's just to kind of give you the heads up on, what we're looking for here and why we're doing this. The point is that, we may be the first and only chance for a patient who has a potentially life-threatening cardiac abnormality to get diagnosed and treated effectively. We are, and this, we're no longer the meat wagon that we were in the 70s. We're no longer the quote ambulance jockeys. We're medical practitioners. We're getting a great depth of understanding. We're getting more training. We're getting more technology, and we have the ability to catch things on ECG or another assessment tools, and it's our responsibility to do that. You may have a patient who has no medical history who experiences a sudden cardiac dysrhythmia and passes out, and then when you get there, they seem to be fine, and your ECG and assessment may be the one time that they're going to have an opportunity to get to the hospital and get diagnosed with something. And it's therefore our responsibility to make sure that we're doing a really good assessment on these people. We're giving our patients the best shot at staying alive and not having a problem down the road. So what's the word? 12-lead ECG on every syncope and near syncope. And we're looking for a couple things. We all know how to look for the STEMIs, so we know to look for ST elevations, and STEMIs are something that gets beat into us pretty good. We all know our dysrhythmias, the things that can go fast or slow that make us pass out. Today we're going to talk a little more about ECG abnormalities, and there's 5 that I'm going to go over. I really enjoy the ECG stuff, and I think it's, as a provider and a paramedic, if you want to embrace something that's kind of cool and interesting and there's a lot of science behind it, ECGs are kind of fun, and there's a lot of really good information out there on the internet to look at, and a lot of books you can read that'll help you do this. But I learned actually very recently that there's a specific presentation on ECG for people who are having a catastrophic cardiovascular or cerebral vascular incident. So you never know. There's all kinds of weird stuff out there, and having a little bit of knowledge will help out. Remember, we are not cardiologists. So as much as a lot of us would like to be doctors, and sometimes we feel like we're as smart or smarter than the doctors. We don't have 8 years of medical school, and we don't have a humongous cardiology background. Most of us are not doing multiple 12 leads every day on a regular basis, so we really can't be expected to make diagnosis, and I want to make that very clear. We're not diagnosing things. We are not cardiologists. When we see things on an ECG, because of our inexperience or just because we have never seen something before, we may be concerned by it when it's not really concerning. So some findings alone may be inconclusive. Sometimes there's anomalies that look dangerous, they aren't. And then conversely, sometimes people have pretty normal looking ECG and they can still have acute cardiac problems. So we are not going to tell anybody definitively in the field that you should not go to a doctor or that you are perfectly fine. We're not going to say those things, and we're not going to scare them either and say, I know that you have a serious cardiac issue. But what we can do is basically our job as EMS. Assess a patient, do the most in-depth study we can of the patient with the equipment we've got, and then advise them to go see somebody, that there may be some need for further investigation. And if we see ECG abnormalities, we have a couple different options, but we can say, look, this is something that I'm a little concerned about. It may be nothing, but it might not be a bad idea for you to go to the ER. I'm going to underline the word prudence here. So I like prudence, and this is a good word. It may be prudent for you to go and see a doctor. And that's something we can document in our PCRs as well, not just to cover ourselves, but to say, hey, we told this person that they really should go to the hospital because there may be a problem there. So not diagnosing, but we're looking and we're advising. So to begin, we're going to have to do a little bit of research on what is a normal 12-lead ECG. So this should be a review for most of us, and we have all seen 12 leads, and we've all been trained to do 12 leads, but this is what is normal, or the finger quotations, normal in a 12-lead ECG. Remember, some people are just going to have anomalous things because they do, and they're not having any kind of cardiac problems. But on a normal 12-lead ECG, we're going to see a P wave that's got a consistent PR interval. There's going to be a QRS complex associated with every P wave. Our heart rate is going to be between 60 and 100. We're going to have upright T waves for the most part, and then we're going to have no ST elevations or depressions. QT interval is something that we'll talk about a little later in this presentation, or possibly the next video, and it's something we don't deal with too frequently right now, but it's something to be aware of. And then we're also going to look for in what we call a normal R wave progression, which we'll go over. So these are going to be the earmarks of a generally normal 12-lead ECG. So here's an ECG that we would consider, normal. We have our P wave, so here's our isoelectric line. We have our P wave. We have this spot right here, which is our PR interval, and it should be between 0.12 and 0.2 seconds. We have an associated QRS with all of our P waves, and then we have an upright T wave there for repolarization. Our rate is, in this ECG, somewhere in the 80 range. We don't have any dysrhythmias. We don't have any ectopy, as far as we can see, is PACs or PVCs, so that's good. And then we talked about this this R wave progression thing. So if you look in your precordial leads, V1, as you progress from V1 down to V2, V4 through V6, what we should be seeing in a normal 12 lead is that the V1 should be a predominantly downward QRS. And then that should slowly change to a biphasic or up and down QRS complex. And by the time you get to V4-ish, you should have a predominantly upward QRS complex that remains throughout the rest of your precordial leads. So this is what we call a normal R wave progression, or a good R wave progression. That we have this starts off mostly negative, transitions through V2 and V3 into V4 as mostly positive, and ends on mostly positive. So this actually is an interesting finding, and if you, of course, you're only looking at this half of the ECG on this one, but if you find that somebody has a abnormal R wave progression or no R wave progression, let's say they're all biphasic or they're all negative and they never really go anywhere else, that finding, combined with new onset chest pain and other things in the clinical setting, can actually trigger problems, or at least the thought of having an acute coronary syndrome and an acute MI. In fact, if you do a 12 lead on a patient and they do have a poor R wave progression, generally somewhere on top of the 12 lead where the diagnosis is, it'll say something like consider anterior infarct. And then, I don't recommend following the computer all the time on the ECG because a lot of times it's wrong, but they'll say, ischemia or infarct, and take a look at that. So you take a look. If you find ECGs online with poor RF progression, when you see the diagnosis on the actual computer, a lot of times will say that. So now that we have the roots of a normal 12 lead, let's take a look at some things that are possibly abnormal. And we're going to start this with the second video.